Welcome to this Step 3 review on postpartum care, brought to you by Roadmap to Residency. Postpartum questions show up again and again on this exam, and they are very pattern-driven, which is good news for you. Today, we are not going to reteach all of obstetrics. Instead, we will show you how the postpartum question stems are built and how to attack them, covering immediate postpartum management, the postpartum hemorrhage protocol, breastfeeding support, and postpartum depression screening. Make sure you are also working through your question bank and the postpartum chapters of a solid review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn how to manage the immediate postpartum patient and how to tell at a glance whether she is stable or quietly deteriorating. Second, we will walk through the postpartum hemorrhage protocols step by step in the exact order the exam wants to see. Third, we will cover breastfeeding support, where the safe answer almost always keeps the mother nursing. And finally, we will tackle postpartum depression screening and how to separate the dangerous diagnosis from the common one. Along the way, we will work through practice questions together and explain why each answer choice is right or wrong. This video assumes you already have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is reading the immediate postpartum stem the way a working physician does. Start with the last line of the question. That sentence tells you what is actually being asked, whether it is the next best step, the most likely cause of bleeding, or the best initial treatment. Once you know the question, go back to the stem hunting for the key details. Then anchor on the vital signs and the uterine exam, because in the postpartum patient, the numbers tell the story. A soft, boggy uterus with a rising pulse and a falling blood pressure screams hemorrhage and a hands-on intervention. A well woman with normal vital signs at her checkup points you toward screening and counseling. Train yourself to read the vital signs as a clue, never as background noise. Strategy 2 is the postpartum hemorrhage mindset. The single most important idea is to find the cause first. The most common reason for heavy bleeding right after delivery is a uterus that simply will not contract, which we call uterine atony. So when you see a soft, boggy uterus, your very first move is firm uterine massage, not a trip to the operating room and not an immediate ultrasound. Be very suspicious of answer choices that escalate to surgery before the simple bedside steps have been tried. At the same time, you treat while you resuscitate. That means placing 2 large bore intravenous lines, giving fluids, and ordering a type and crossmatch. If massage alone does not work, the next answers are medications that contract the uterus, chosen carefully based on the mother's other medical conditions. Cause first, resuscitate alongside. Strategy 3 is running the postpartum hemorrhage protocol in the right order, because the exam loves to test whether you know what comes next. First, start with massage and resuscitation. For a soft uterus with heavy bleeding, begin firm bimanual uterine massage while you call for help. Place large bore access and give fluids. Massage often fixes atony all by itself, so only move past it when the stem tells you it has already failed. Second, match the medication to the mother. Oxytocin is first line. The classic trap is picking a drug she cannot safely take, so avoid the prostaglandin that worsens asthma in a woman with asthma, and avoid the ergot medication in a woman with high blood pressure. Third, escalate only after medications fail. Balloon tamponade and surgery come last, never first. If a stable patient is rushed straight to the operating room, that is the overkill trap. Let us work through our first practice question, and this one tests the postpartum hemorrhage protocol. A 26-year-old woman has just delivered a large baby after a long labor. Minutes later, she has heavy vaginal bleeding. Her pulse is rising and her blood pressure is drifting down. On examination, the uterus feels soft and boggy and sits high above the navel, and the placenta was delivered intact. The question asks for the most appropriate next step. Look at your 4 choices. Option A is firm bimanual uterine massage. Option B is straight to the operating room. Option C is the ergot medication regardless of blood pressure. And option D is a pelvic ultrasound before doing anything else. Pick your answer now, and then we will break it down together on the next slide. Let us break this down. First, spot the pattern. A soft, boggy uterus with heavy bleeding right after a long labor and a large baby is textbook uterine atony, which is the most common cause of early postpartum hemorrhage. The long labor and the big baby are the risk factors that overstretch the uterus. Now apply the rule. The first step for atony is firm bimanual uterine massage, done while you call for help. Place large bore intravenous lines and give fluids. Massage is fast, costs nothing, and very often stops the bleeding on its own. So the answer is option A, perform firm bimanual uterine massage. Now eliminate the wrong answers. Going straight to the operating room skips the simple step that usually works. Giving the ergot medication regardless of blood pressure is dangerous because that drug can be harmful when blood pressure is high. And ordering an ultrasound first only delays treatment in a patient who is actively bleeding. The answer is firm bimanual uterine massage. Here is our second practice question, and it is all about breastfeeding support. A 30-year-old woman who is breastfeeding her 3-week-old infant has 3 days of pain and redness in one wedge-shaped area of the right breast, along with fever and body aches. The area is firm and tender, but importantly, there is no fluctuant mass. She is otherwise well. The question asks for the most appropriate next step. Your choices are: option A, tell her to stop breastfeeding from both breasts. Option B, continue breastfeeding and give an antibiotic that covers skin bacteria. Option C, order an urgent breast biopsy to rule out cancer. And option D, drain the breast in the operating room today. Choose your answer, and then we will walk through the reasoning together. Let us work through this answer. First, spot the pattern. A nursing mother with a tender red wedge of breast, fever, and body aches, but no fluctuant mass, has lactational mastitis. That detail about there being no fluctuant collection is the key. It tells you this is an infection of the breast tissue, not an abscess, which is a walled-off pocket of pus that would need draining. Now keep the milk flowing. The correct answer is option B, continue breastfeeding, and give an antibiotic that covers skin bacteria because emptying the breast is actually part of the treatment for mastitis. Telling her to stop nursing is wrong and only makes the engorgement and infection worse. A breast biopsy and a trip to the operating room are both overkill traps when there is no mass and no abscess. The answer is to continue breastfeeding and give an antibiotic that covers skin bacteria. Now let us zoom out to a general strategy for breastfeeding support stems because they follow 2 simple rules. First, keep the mother nursing. On the exam, the safe and correct answer almost always continues breastfeeding. For sore nipples, the fix is improving the latch and positioning, not stopping. For engorgement and for mastitis, continued emptying of the breast is part of the cure. So when an answer choice tells a healthy mother to stop breastfeeding, treat it as a likely trap. Second, know the few real contraindications, because the stem will make them obvious. Breastfeeding is genuinely not allowed in only a handful of situations, including the human immunodeficiency virus in a high-resource setting, active untreated tuberculosis, certain chemotherapy drugs, and drugs of abuse. Outside of these clear-cut cases, the better answer supports and continues breastfeeding. Here is our third practice question, and it covers postpartum depression screening. A 28-year-old woman comes to her 6-week postpartum visit. For the past month, she has felt persistently sad, has lost interest in things she used to enjoy, sleeps poorly even when the baby is asleep, and feels worthless. Crucially, she has no thoughts of harming herself or the baby, and she is not confused or hearing voices. The question asks for the most appropriate next step. Your options are: option A, screen with a validated depression questionnaire and arrange treatment. Option B, reassure her that this is normal baby blues and do nothing. Option C, admit her urgently to a psychiatric unit. And option D, tell her to stop breastfeeding before any treatment can start. Lock in your answer, and we will break it down next. Let us break down this answer. First, spot the timeline. Her low mood, loss of interest, poor sleep, and feelings of worthlessness have lasted more than 2 weeks, in fact a full month after delivery. That duration takes her out of the brief baby blues and into postpartum depression. The right answer is option A, screen with a validated depression questionnaire and arrange treatment, which usually means therapy, a safe antidepressant, or both. Now the key distinction, and this is where the wrong answers fall away. Baby blues resolve within about 2 weeks, so calling a month of symptoms normal and doing nothing is wrong. Urgent psychiatric admission is reserved for thoughts of self-harm, thoughts of harming the baby, or psychosis, and she has none of those. And telling her to stop breastfeeding is unnecessary because safe medication options exist for nursing mothers. The answer is to screen and arrange treatment. Here is a critical exam day pearl that ties the postpartum mood questions together. There are 3 postpartum mood states, and the STEM is always pointing you at one of them. The first is the baby blues, which are common, mild, and brief. They start within a few days of delivery and resolve on their own by about 2 weeks. And the right answer is reassurance and support. The moment the STEM stretches the symptoms past 2 weeks, or adds worthlessness and loss of function, it has shifted into postpartum depression, which needs screening and treatment. The third state is postpartum psychosis, and this is the emergency you cannot miss. Look for confusion, hallucinations, delusions, or thoughts of harming the baby, often within the first week or 2. Psychosis needs urgent psychiatric admission and is never managed at home. So watch the clock and watch for those red flags, and let them tell you which of the 3 you are dealing with. That wraps up our review of postpartum care for Step 3. Remember the core patterns we covered today. Read the immediate postpartum STEM by anchoring on the vital signs and the uterine exam. Run the hemorrhage ladder in order, starting with massage, then the right medication for that specific mother, and surgery only as a last resort. On breastfeeding stems, keep the mother nursing unless there is one of the few true contraindications. And for mood, use the timeline to separate the brief baby blues from postpartum depression, and never miss the red flags of postpartum psychosis. To really lock these in, drill them in your question bank and review the postpartum chapters of a trusted review resource. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized plan. If this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.